Patient-Centered Care with Linnea Van Pelt, BSN, RN, OCN, LMBT, Caregiver Burnout, How the Pandemic Helped Shape This Nurse's Understanding of the Road Ahead in Our Cancer Care Communities. Linnea, welcome. We're so glad to have you with us today.
Thank you so much, Tim. It's an honor to be invited back to present to this forum.
Oh my gosh, we're really pleased to have you back. BSN, RN, OCN, LMBT, comprehensive holistic care patients and their loved ones, and you're the patient services manager for the UNC Oncology Support Services Department at the NC Bass Knight Cancer Hospital. And kids, husband Jeff, and kids Eva 11 and Ethan 8, and domesticated and stray animals. Tell us about the stray animals.
Well, that's all due to my daughter Eva, who has a big heart for animals of all kinds. So we've definitely adopted a few who live in our garage.
That's great, and then a big puzzle fan as well. All right. Well, we've got some other information, and this one fascinated me. I want to ask you a little more about this, but was featured on NPR's Prairie Home Companion for a poem you wrote in high school. Can't let that one pass by. Tell us a little more about that.
Yeah, so for those of you who aren't familiar with the Prairie Home Companion, it's an old radio show. I'm not sure it's still on the air. But growing up in Minnesota, it was a regular event for my whole family. Every Saturday night, we tuned in on the radio. And it was kind of a variety show with good, Midwestern humor and lots of laughs. And every spring, they did a poetry contest. And on a whim, my senior year of high school, I submitted a poem that I'd written the year before, really just celebrating spring and how excited and heady and wonderful I feel in the spring in Minnesota after a very long, dark winter. And I was chosen as a finalist. So I was on the air with Garrison Keeler and the other finalists as he read our poems. And unfortunately, I didn't win the sleep number bed, which was the grand prize. But I did get a signed autographed picture of Garrison Keeler, which was pretty cool.
Oh, that's great. And so you were up there at the theater in St. Paul for that?
No, just on the phone.
On the phone. Okay. Well, that is so cool. That is great. Thank you for sharing that. Also awarded an NC Great 100 Nurse in 2017. Congratulations. Went back to school for massage in 2019 and received her massage and bodywork license in 2021. Is representing her team at the White House on behalf of their work on oncology navigation next week.
That was actually a couple of weeks ago now.
That's what I was thinking. How did that go?
It was incredible. It was a wonderful experience. I got to meet see a lot of folks that I've met at various navigation events, but definitely something I'll never forget.
Wow, congratulations again. And awarded Nurse of the Year for UNC Surgery Services in 2019. So thank you for sharing all of that with us. I mentioned Poll Everywhere, our softball question. Caregivers should handle all responsibilities alone without seeking help, true or false? This is kind of a nice way. I'm guessing most of you are going to get this, but this is a nice way for everyone just to go ahead and use Poll Everywhere there, and we're going to jump right into that one. So caregivers should handle all responsibilities without seeking help. What do you think? I'm not going to wait too long on this one. I see false. We're at 100% on that. Yeah, seek help.
Good job. A+.
Absolutely. Linnea, I'm going to turn this over to you. We're thrilled to have you here. Thanks so much. Caregiver Burnout, How the Pandemic Helped Shape This Nurse's Understanding of the Road Ahead for Our Cancer Care Communities.
All right. Well, thanks again, Tim, for the warm welcome and the little dive into my other life. And again, for the invitation to present in this forum. It's truly an honor. And I'm excited to share just some thoughts and reflections as well as some research with you all today. But I will be honest, when I was first asked to present on caregiver burnout, I did feel a little bit overwhelmed and even a little bit intimidated. And that's because there are so many different aspects of this topic to consider. For one, there are many different types of caregivers, some of whom do it for love, taking care of a family member, or because of social obligations. And like many of us here, a lot of us do this for a living. And a lot of us do it in all of these domains, sometimes simultaneously. And they all have implications on so many different aspects of our life. Most informal caregivers are family members, but some are also friends, neighbors, members of faith-based communities. And then, of course, you have the healthcare industry that includes many different types of professional caregivers. The fact is, all of us, no matter who we are or what kind of work we do, at one time or another, find ourselves in the role of caregiver, whether we plan for it or not. And this is really a good thing. None of this is bad. We are built for community, and we know from research that social isolation is actually a risk factor for poor health outcomes. So we know that we need each other. But when caregiving responsibilities overlap and stack up and become overwhelming, or when the resources we need to shoulder those responsibilities aren't available, I think any type of caregiver can experience burden and burnout. I think we're missing a slide. Okay, I apologize for that. I will read you through it. So the next slide was intended to be a working definition of caregiver burden. And the reason I really like this definition is because it covers so many different domains and also acknowledges why the terms burden and burnout are really hard to objectively define. So the definition is the extent to which caregivers perceive that their physical health, psychological health, schedule, social life, and financial status have or are suffering due to providing care for a cancer patient. So this is specific to cancer caregiving. And I think it's really telling because it's so easy to assume that the way things are the way things are supposed to be. And as professional paid caregivers, we tend to ignore or simply not realize the extent to which our responsibilities at work impact us in all of these other domains. But for the informal caregivers who are caring for our cancer patients at home, this is even more pronounced because they often feel like they never had a choice to assume these burdens in the first place. So when I started reading about, forgive me for my technical difficulties. Okay. When I started reading about and considering what aspects of caregivers I wanted to talk about today, I began by reflecting on my own experience because really I have experienced caregiving in all of these different ways. I am obviously someone who has chosen a career in caregiving. And with that career, I receive a whole lot of personal fulfillment and really good compensation. But aside from work, I'm also someone who is a daughter, a spouse, a parent, a neighbor, a friend, a member of a faith community. And I've been surprised so many times along the way by unexpected caregiving obligations outside of work. And unfortunately, like so many others, cancer has impacted some of those relationships for me. So to frame this up, I'd like us to think about the road of caregiving and all the different milestones that we have personally passed along the way. So I'm going to share just a couple of the milestones that are now in my rearview mirror, just to acknowledge what I am carrying with me to this topic. As it turns out, I know everybody will be shocked to hear this. As a post-pandemic oncology nurse, I've got some baggage, but we're going to call it luggage in this context when it comes to some of those milestones and the burnout that has sometimes resulted. Don't worry, this lecture is not about my life story. It just reminds me that all of us bring our own luggage on this journey and likely have multiple types of caregiving milestones. So I offer this, I hope, as a useful framing as you all think about how this topic impacts you professionally, personally, and probably both. So I had two really formative caregiving experiences growing up for two of my grandparents separately from either side of my family. Both of them required physical, medical, practical, psychological, emotional, and financial support from my parents towards the end of their lives. And I was right in the middle of it because they lived at home with our family. I learned to bathe, clothe, feed, sometimes distract, and spend time and love and watch over my grandparents as they aged and got sick. I learned how to guide my grandfather back home when he wandered away, even when he was very angry, and how to get him back home safely. I learned how to guide my blind grandmother safely to and from the bathroom, and have blurry memories of finding her on the floor after I came home from a shift at the coffee shop, and then of her in the hospital and then a nursing home after that, after having a stroke. And when I think about the rest of my family, my parents at the time were both middle-aged, so essentially the age I am now, working full-time. They had me and 3 older siblings to care for. And at the time, this all felt in many ways normal, but also strange to me because none of my friends had grandparents in their home or had any type of caregiving responsibilities. As you can imagine, ultimately, these experiences did lead me to pursue a career in nursing, although it was definitely not a straight path there. But shortly after starting nursing school, my mom was diagnosed with breast cancer for the first time. This was my first experience as a cancer caregiver and also a caregiver from a distance because I was in North Carolina and she was in Minnesota. And this was such a unique role that I found so exceptionally emotionally difficult. I called my mother every single day during her treatment and in nursing school learned everything I could about her diagnosis and treatment. I experienced the terror that the word cancer drives through your heart when it's connected to somebody in your family. Those daily phone calls were really as much for me as they were for her. But I have to note that at the time, I was not a caregiver for anyone else at this point in time, and my mom did exceptionally well with her treatment. I didn't have kids yet, and thankfully, my husband and the rest of our immediate family was very healthy. When my mom was diagnosed again with a different type of breast cancer on the opposite side, I was 11 years into my career as a nurse, and things looked a lot different. At that point, we were right in the middle of the pandemic, so I was working much more than full-time. I was also in massage school, and I had 2 young children at home. And even though I didn't recognize it at the time, remember this is based on perception of impact and suffering, I was definitely facing my own version of caregiver burnout. That being said, I was super grateful that I had a job that allowed me time off to fly to Colorado and take care of my mother after her mastectomy. And that same job had already provided me with years of knowledge and experience in post-op surgery care. So I'd like to kind of switch gears and examine the road ahead and who else is on the road with all of us in terms of caregiving, and really talk through what I think we as a professional cancer care community can do to support some of the other drivers on this road, especially those who we call informal caregivers. You can think about them as unlicensed caregivers.
And Linnea, please forgive me. We discovered, as you did, that there were a few slides that somehow were removed. If you can bear with us for one moment, we will go ahead and insert those slides back in. It will just take Andrew a second here.
Sure, sounds great. So like I said, I'd just like to kind of look at the road ahead, as well as, these other types of caregivers that are sharing the road with those of us that are more or less doing this professionally. And as you'll see in my next slide, it turns out that there's been quite a bit of construction when you think about the road of cancer caregiving and cancer care. This is not news to anybody on this call, I'm sure, but I would like to highlight a few improvements in cancer care and really then ponder some of those unintended consequences of those really good things. So cancer treatment is improving all the time. We know this. This means that patients are living longer, sometimes cancer-free, or are on long-term maintenance therapies that allow for relative comfort and independence. A lot of treatments, especially oral therapies, but even infusions and injections that used to require hospitalization, are now given relatively safely at home or in an outpatient visit where the patient goes home immediately afterwards. In fact, there were 2 just in the last month infusion treatments previously only given in an inpatient hospital stay that have been approved to be given in our outpatient infusion center right here at UNC. Obviously, this is undeniably good news for our patients. But frankly, it's a little bit of mixed news for our informal caregivers. If we return to our metaphor, think about it like the construction foreman, the construction crew, the traffic control people, the folks on the GPS that were all there, supporting professional caregivers and caring for these patients have essentially all disappeared. Maybe they're working from home. And the driver of the car, who is now the informal caregiver, is now responsible for navigating this construction zone with very little, at the elbow guidance. There we go. That looks familiar. This means that these informal caregivers are managing very complex side effects like pain, anxiety, and nausea, a lot of new and unfamiliar medications, issues with physical mobility and support for activities of daily living, mental health and emotional support, and all of these things also shift quite a bit of financial burden directly to the family unit because it's different from the types of services you would receive in a bundled hospital stay. So when I consider this kind of big shift as a nurse, it's understandably a little bit alarming. Now I know that patients are supposed to be released from the hospital when they, quote, no longer need hospital level care. I get that. We also know that doesn't always happen. We know as well how quickly level of care needs can change, especially with cancer patients. So I do think it's worth comparing what resources formal professional caregivers have versus informal caregivers at home. When I think back on my inpatient days, I took care of 6 patients every shift for whom I was responsible. Obviously, that's a responsibility I took very seriously. But I had great support from senior nurses on my unit. I had access to essentially any medication, any wound care supplies, any medical devices, any monitors that I needed that were just a few steps away. I also had respite in the form of the oncoming shift. And many of you know how that feels, that deep relief after a really hard shift when you can hand off patient care to somebody that you trust and go home and rest and live your life. And of course, in the hospital setting, you have doctors and nurse practitioners and pharmacists on call, and really an entire infrastructure of expertise to help you take care of your patient. And of course, I was paid for it, and I was paid well to do it. Conversely, when you look at informal caregivers, research and common sense tells us that informal caregivers have even more responsibilities vis-a-vis their loved ones, both in the medical and non-medical spheres, but they have a lot less support. Informal caregiving requires loved ones to provide care that they are not or only minimally trained to do, with less reliable access to supplies. Often those are very expensive, and they may not be available when needed. In addition, informal caregiving is often round the clock, financially burdensome, and very isolating care, with only fragmented support structures like after hours triage lines, which may be staffed by folks not familiar with their loved one's condition, home health services if they're lucky enough to qualify, but which can sometimes be intermittent or unreliable, and emergency services care for those moments of crisis. And usually those services are not specialized in cancer care. And of course, these informal caregivers are not getting paid. So they probably have to try to figure out how to make some money at the same time. So the problem I see with this new stretch of road, as treatments have improved and shifted care to outpatient settings and to the home, is that the robust support structure that we have as formal paid caregivers has not translated to support for our home-based, unpaid, and often unprepared caregivers that we all rely on to take care of our patients. It's no wonder then that research shows that these informal caregivers experience very high levels of caregiver burden, to the extent that it can often adversely affect their own health and well-being. We are seeing, the evidence shows, increases in anxiety and depressive symptoms up to 40%, as well as changes in social relationships, all of which may impact the ability of these caregivers to provide care for their loved one. Before we move on, I do want to emphasize again that all of this has significant financial implications on our informal caregivers and their households. When you think about a hospital stay where a patient has all of their basic needs met, they have food, they have a warm bed to sleep in, they don't have to worry about any of those overhead costs, they have transportation to and from whatever procedure they need, and they have round-the-clock assistance with their activities of daily living. When all of that shifts back to the home, the financial burdens associated with those typically add up on the non-insurance covered side of the family ledger. What you'll see in this graph is how much of this burden happens on a daily basis for the majority of our informal cancer caregivers. And especially the bottom half, which are considered indirect activities of daily living, all of these in some way represent costs, real costs to the family unit. So to kind of summarize the observation of our current state, our current road conditions, we have made incredible progress in treating cancer. And this is an incredibly wonderful thing. But it has also resulted in an infrastructure problem that does not adequately support our informal caregivers. In other words, there's not really a DMV helping these caregivers train for the road ahead. We are really leaving them mostly to navigate on their own without adequate training, skill building, respite, and opportunities for self-care. I believe we can, I believe we should, and I believe we will do better. We're going to turn in a minute to a concept of a new type of DMV. This one is the Department of Meaningful Value, to help address some of these unmet needs and keep everybody on the road safer as a result. But first, we will do our first question to make sure you all are still awake. The question is, which of the following nursing-like activities have become regular responsibilities for informal home-based caregivers? Options are medication management, symptom management, activities of daily living, or all of the above. So there's really no wrong answer here, but of course what I was looking for was all of the above. These are all tasks that were, that are always done on an inpatient settings and now often done as well in the home. Okay, so we're gonna shift gears just a little bit and explore not just the road conditions, but also who are these informal, quote unquote, unlicensed drivers that are sharing the road with us. I don't in any way mean to imply unlicensed in a pejorative way. This is really just a reflection of folks that were kind of thrown into the driver's seat of a car that they don't know how to drive, with a semi truck in the rear view mirror, and they're heading right into an active construction zone. There are many studies out there that describe the demographics of informal caregivers. Most of them align to a majority being middle-aged female family members. Although, of course, there are plenty of other varieties, including unrelated caregivers like friends and neighbors. But let's consider this kind of particular snapshot or profile of a driver who is a white middle-aged female, much like myself. Let's assume for a moment that she is married, that she has a full-time job, but not in a healthcare field. Both her and her spouse's incomes are needed to support themselves and their 2 teenage sons. And her parents are aging and starting to need more help with daily tasks like grocery shopping, etc. After multiple trips to the emergency room and to his primary care physician, they've learned that her spouse has colorectal cancer, and he will need surgery, chemotherapy, and radiation. His health insurance is through his work, but he will be unable to work during treatment because the surgery will result in him being unable to sit for long periods of time, and he will need that daily radiation. So he is definitely in danger of losing his job and thus his health insurance. Unfortunately, our caregiver is pretty new in her job, so she doesn't qualify yet for FMLA or Family Medical Leave Act. So taking the time off work for his surgery and for that daily radiation regimen is a big problem. In addition to that, she will need to learn how to care for her husband's new colostomy, for the surgical wounds, and ultimately for a chemotherapy infusion pump that he will take home with him. On the plus side, thankfully, her husband does have a sibling nearby and is able to help some with the teenage boys and the transportations that they need. But that's very hard to coordinate with her work schedule. This informal caregiver was an avid runner and really dedicated and tried hard to provide healthy foods for her family. But with all of this added stress, it's really difficult for her to find the time and the energy to exercise. And she has simply been too exhausted to plan meals and is regularly picking up fast food on her way home. This informal caregiver has a lot of things to learn and maintain in order to keep the car moving along, doesn't she? Now, I'd like you to imagine the millions of other profiles of caregivers that may have even less support, more barriers to care, no or inadequate insurance, and perhaps other intensive caregiving obligations. And I think you'll start to see and feel a bit of what this type of caregiver burden can feel like. All right, we're going to try one more question. Looks like the majority found the right answer. The question was, which of the following statements is true related to the characteristics of informal caregivers for cancer patients? And I threw some distractors in there on the other answers, but was looking for an acknowledgement that really up to 10% are not direct relatives of their patient, including neighbors and friends. Well, we're going to shift gears again, and I want to kind of lean back into the lessons that we as professional caregivers have learned in the healthcare industry since COVID. And I know this may seem odd, but I do think there is synergy between the crisis that we felt as formal caregivers when COVID hit and the crisis that our informal caregivers are thrown into when they receive a cancer diagnosis in the family. And I believe that further, if we can examine what went well and also what did not go so well in our industry during that time of crisis caregiving, we can hopefully start to move the needle a little bit from crisis-based or reactive caregiving to proactive support for all different kinds of caregivers. So when I think back on March 2020, one of the biggest stressors for me when COVID hit was the lack of information and knowledge about what the heck was happening. We had so many questions without answers and felt like we were literally groping in the dark, worried not only about our patients, but about ourselves and our families. And like we always do, we pulled together, we put on our masks. A lot of us wore that same mask for 5 shifts in a row because we had to, and we did the best we could with the limited information we had. At the same time, I remember trying desperately to reassure one another that everything was going to be okay. That reassurance is hard to believe in the moment, but it's essential because it helps us stay connected to one another, and it helps us know that we can do hard things as long as we do them together. In addition to that solidarity and support from our fellow kind of formal caregivers, another huge thing that kept me going was the overwhelming gratitude from our community. It was literally poured all over us in the form of strangers buying my family's takeout dinner that I ordered after a long shift just because he saw me standing there in scrubs, chalk messages on the sidewalks. My neighbors wrote me notes of encouragement on my driveway, and lots and lots and lots of food. It truly gave me strength when I thought I was done, which leads me to the next bullet point, and that is grace. The ability to forge ahead imperfectly after you've had a really tough stretch, made some mistakes, and to really find that spot of forgiveness and perseverance. As things started to become a little bit clearer during COVID, we learned more. We continued to make more mistakes, of course, but we also started to break down some of that initial barrier of lack of information and knowledge and train up to be better prepared for whatever laid ahead. I was trained, for example, to work in the ICU if that became necessary. We figured out how to protect ourselves with the appropriate PPE. And with all of that, we started to feel like, once again, we were capable of meeting the needs of our patients. The last two bullet points are really tough, and I think they're tough for caregivers of all different stripes. I personally learned these the hard way during COVID. It took months of mistakes for me to find healthy habits to sustain myself, and then the confidence to ask for the flexibility I needed, both from my family and for my family, to make sure that we could keep going. I really believe that these lessons can be applied in a more proactive way to build a better support structure for our informal caregivers. They need information, knowledge, and reassurance that they are also not alone and that they are capable of doing hard things. Gratitude is interesting in this context, and it's also the subject of a lot of recent research since COVID. And I just want you to think about these questions. When was the last time you looked at an informal caregiver and thanked them for taking such good care of your patient? Or provided some sign of appreciation for the endless hours of unpaid care that they are providing? Can you imagine what would happen if those of us in healthcare did this regularly? Something to think about. Moving on to grace, which is, I think in this context, the act of providing space and validation for mistakes, for breakdowns, for grief, for anger, for all of it. And in addition to that, encouragement for creating or sustaining healthy coping habits, providing supportive and flexible space for family members and for caregivers to continue to do things like work or go to school remotely. But the two biggest elements that I think distinguish proactive caregiving from crisis caregiving are the two that are bolded and italicized here. And interestingly, I think those two are things that we already had in our formal caregiver roles when COVID hit, but that our informal caregivers often lack. And that is comprehensive training for the task at hand. Yes, we didn't know everything, but we were all skilled to perform the types of skills that were needed. And also that ability to hand your patient off at the end of a shift. I really believe that in both of these areas, we can work to make things better for our informal caregivers as well. Yeah. So the research has actually done a pretty good job, again, of showing us who these informal caregivers are and how they're impacted by the burdens that they're shouldering. The research also points out that there is an incredibly underappreciated financial value that informal caregiving contributes to our society, to the tune of $470 billion with a B dollars every year. Now, there's a lot that goes into that number, of course, including those many hours of unpaid labor, but also the cost savings of moving treatments out of the hospital, which unfortunately means that in spite of the high value care that these informal caregivers are providing, they are now experiencing a significant financial burden as a result. Of course, value is not just monetary, although non-monetary value is much harder to objectively describe. There's been a lot of interesting research lately, and I mentioned this earlier, into how loneliness and social isolation can negatively impact health. And actually, I heard just earlier this week an interview with a researcher who described how social isolation can be just as harmful as smoking 14 cigarettes a day and can be directly correlated with decreased life expectancy from all diseases. And I think intuitively this makes sense to many of us. I know I have seen this so many times as a nurse. Those patients without family, those patients who are alone, who do not have significant support or caregivers at home, almost always seem to suffer worse outcomes. This is common sense, right? We know social connections are the essential building blocks of our lives. They provide mutual love, purpose, and joy. And without a doubt, it's our informal caregivers that are providing the majority of this for our patients. And I think that is worth calling out and acknowledging. So yes, we know that caregiving is undervalued. What should we be doing differently? So back to this concept of the Department of Meaningful Value, the new DMV, I think it does start with that acknowledgement. And then after that, I think there are multiple ways to approach this. If we go back to the items on the list on the previous slide, let's start with the first one, which is information or knowledge. Caregivers, when you think about it, they don't get to go to nursing school before they're deemed ready to take care of their patient. So they need real-time, accessible information about the disease and the treatment, their loved one is facing. They also need real, practical training on how to keep their loved ones safe as they walk or transfer from the bed to the chair or the toilet when they're feeling so weak and so fatigued from treatment. Medication administration is a very significantly risky knowledge gap for most people. I can't even begin to describe the number of hours of training on medication safety and the 5 rights of administration that were drilled into us in nursing school. And when you think about it, most informal caregivers get a list of medications on discharge from the hospital or from the clinic. And if they're lucky, maybe a short education session with a nurse or a pharmacist during an already stressful day that talks about these medications. But side effects and symptoms of the disease can be interrelated and very overwhelming. And caregivers can be hesitant about either over-medicating or under-medicating their loved ones to keep them comfortable. They are told to expect some things like nausea and vomiting, but seeing your loved ones suffer those things at home without anyone around you to support is an entirely different experience than reading it on a piece of paper. As you know, when you are a healthcare provider or a formal caregiver, depending on your setting, you often have exactly what you need to take care of the patient in terms of medications or supplies to take care of wounds, etc. And often we don't even think about what those things cost. But for our caregivers at home who are already faced with overwhelming costs and medical bills, this can be completely overwhelming to add in all of these incidentals. Cancer care, it's not incidental that cancer care is actually one of the leading causes of financial toxicity for families. Of course, there's no easy fix here, but I do believe that financial support and navigation for some of these out-of-pocket costs associated with care is something for which we can build in some practical support. Aside from all these practical things, All of the other things on the list from the previous slide are arguably just as important. We covered some of it already, but I think it's worth repeating. What does providing meaningful reassurance, gratitude, and grace look like? Many of us already do this intuitively, but I think if more of us did this intentionally, it could have an incredible impact on our informal caregivers. And like I shared earlier, teaching and encouraging healthy self-care and providing those safe and flexible spaces for families is absolutely essential. Okay, we're going to do one more quick question and then we'll be wrapping up. So what are the two domains of under-resourced and much-needed support for informal caregivers? All right, y'all are just knocking it out of the park. We all, I think, are participating in some shopping therapy right now, but the right answer is practical medical task training and mental health support. Great job, you guys. Okay, so I know we're getting short on time. I wanted to leave you with just two more slides. The first is kind of a 5-minute traffic report. So just to summarize, we know that treatments are improving rapidly. Patients are living longer. This is all good stuff, but it is shifting a lot of care for our cancer patients away from formal healthcare settings, which means that a lot of these essential caretaking tasks are now being done by informal, unpaid, and often unprepared caregivers. We know that caregiver burnout is real. Most of us have lived through multiple iterations of it, professionally, personally, or both. I believe we can do better by leaning into the lessons we've learned as formal caregivers to bring some of that valuable support to our informal caregiving colleagues, and I use that word very intentionally, to better care for our patients. Thankfully, I believe the road ahead is actually quite promising. Medicare is now reimbursing, trying with these slides, y'all. Medicare is now reimbursing for caregiver training, and there are models for this that are being tested right now. One at Rush Cancer Center is really intriguing. It provides practical training for caregivers to help with movement, mobility, medication management, and mental health. There are many new and super innovative digital platforms and tools, including Encompass right here at UNC, that are really identifying ways to keep caregivers better connected to one another, to their communities, and also to their providers. And I'm super excited to share that UNC has hired a nurse navigator with a special focus on cancer caregiving. And she will be learning directly from our caregivers and from all of this research to really help us start to build that department of meaningful value here for our informal caregivers. With that, I will share my resources. I will say thank you for your time and attention and patience with the technical difficulties. And I think we have a couple minutes left for questions.
We sure do. And so we'll go ahead and bring that up. Let me just go ahead and I'll be moderating these questions. So please feel free to start submitting your questions for Linnea. This has been a phenomenal presentation. Thank you so much. And we do have the poll everywhere working. Thanks for bearing with us with some unexpected issues with that. While we're waiting for those questions to come in, first I just want to say thank you as somebody who, as our audience knows, is not a clinician. I'm a technologist. I've been thrown into the role of being an informal caregiver twice in the last 10 years. And it's exciting for you to talk about some of the resources that may be available. What in terms of what you had just mentioned, what sort of time frame are they looking at as in terms of being able to actually participate in that online training? Is that something that someone could potentially go to in a matter of days or weeks to sign up and access that?
Are you referring to the one from Rush Cancer Center?
Yeah, yeah.
Not quite. So it is it's
Mhm.
kind of a package that has been developed, but it does require, some facilitation on the part of the home institution. So that
Mhm.
is something that we're looking into as a possibility to incorporate with our team here at UNC. So I'm very cautiously optimistic about that coming, within the next year or so. It was brought to my attention actually by Dr. Aaron Kent here at UNC, who has been part of kind of the community that has created that product.
Great, great. Well, we'll look forward to more on that. And then let's see that I did see a question that came in. Is the full slide presentation available in the handouts? And yes, that should be available. And I know that John had put the link up earlier in the chat, and that's also in the learning portal. And then we have another question along with the new NN mentioned. The online program sounds like it could be very helpful. Not a question, but a statement. And
Agreed.
and then we've got another this one. How to navigate poor care in nursing facilities. So how would one navigate poor care in nursing facilities?
Ooh,
Any thoughts
that
on that?
that is a really, really tough one.
Yeah.
I think, many of us are, unfortunately, many of us, if, and I'm by us, I mean informal caregivers,
Hmm.
are, at a disadvantage when it comes to having to rely on institutions to provide care. And I know, skilled nursing facilities have a lot of challenges with staffing and with, adequate training for their staffing. And that really does increase the burden on the informal caregiver in that setting. I remember when my grandparents were in nursing facilities, and by and large, they were well taken care of, but the added stress on us when things did not go well, it's a very difficult question.
Yeah. Yeah. I did want to give a shout out. I mentioned one of the promoters, and she did give us permission to use her name. So, Teresa Nuttall, thank you so much for all that you do as a promoter. I did want to share that from what I'd mentioned at the beginning. And then, final question, because we're getting down to 1 o'clock here. Does UNC offer any respite care services to help with caregiver burnout?
So, not officially that I'm aware of, but I do think that is one of those, kind of tangible, practical pieces of this puzzle that we need to work towards diligently in the future. So I hope that will be coming soon.
Great, thank you. And we do have a comment. What a wonderful, excellently prepared presentation. Thank you. And that's from Teresa. And also, what a wonderful, excellent. So we had a couple of comments along those lines, and
Appreciate that.
agree with those. Let's see. We do need to wrap up. So want to say thank you to the University Cancer Research Fund through the state of North Carolina, to the UNC Lineberger Comprehensive Cancer Center, and to the team here at the UNC Lineberger Cancer Network, Benny Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, Barbara Walsh, the song Back Roads, written and performed by Don Poe.